Bariatric surgery is considered to be the most effective, durable tool we have against obesity. Bariatric surgery has never been safer. In fact, a recent study showed that having bariatric surgery is safer than having your gallbladder out. The robotic platform allows more precise surgery to help decrease the possibility of complications after surgery and improve recovery. We've adopted a robotic platform for this reason, so that our patients overall do better and feel better and recover quicker. The surgery goes with you wherever you go, and so it is a tool always there to help you stay healthy.
Dr. K is absolutely amazing. It was amazing how well I felt, even a day after the surgery, even the same day as surgery.
We have been doing cases now since 2013. We are teaching other surgeons, we're leading surgery. This is what we do.
Dr. K's office and his team, they're awesome. I recommend their services to anybody that's looking to do anything with their weight. It doesn't have to be a surgery, just the knowledge itself can change a person's life.
Interestingly enough, oftentimes we see diabetes go away within a few days of surgery. Sometimes people's diabetes is gone before they even leave the hospital. Weight loss happens over time, and the more aggressive procedures tend to give faster weight loss. But the pace at which they improve surprises even me at times. Our patients can expect to see 60 to 70% improvement in their diabetes, and about 80% of our patients will have a complete cure of their diabetes, depending on which treatment they had.
I couldn't even walk across the street without being out of breath, or without my legs hurting, my shins hurting, my knees hurting. I'd say that's the best thing I ever did. I wish I hadn't waited so long to do it.
Of course, the motivation for their operations may be different, but the end result is that their quality of life is better. Overall, our patients are not only healthier, but happier after surgery. If you are thinking about having bariatric surgery, it's important to find a program that is multidisciplinary, comprehensive, and has experienced surgeons that are here to help you with a wide variety of different operations that may suit you best. Please give us a call, 469-620-0222. Thank you very much and have a great day.
Hi, everybody. Dr. Sachin Kukreja here. We're excited today to talk about bariatric surgery, both non-surgical and surgical options. And we're going to go through the process with our program so you know what you might be able to expect. So every journey begins with the first step. And of all the people that are eligible for bariatric surgery, only about 1% of people ever even consider it. So far fewer than that actually pursue it. And this is rather unfortunate because we know that bariatric surgery is the most effective thing we can do to affect people's weight and to affect their health that may be declining because of their weight. So for those of you that are taking an interest in this, congratulations. This is most certainly the first step that you can take in taking control of your health. However, this is not something that we encourage people to do without the support of others. So please enlist the help of family and friends. So a little bit about your surgeon. People always want to know about my background and what I've done, where I've been. My professional training started in medical school in San Antonio, finished back in 2004, followed by going to Chicago for my general surgery and training at Rush and Cook County Hospitals in Chicago. Did a bariatrics fellowship at the Medical College of Wisconsin in Milwaukee, and that was concluded back in 2010, so 10 years ago. In the last 10 years, I've directed 2 bariatric surgery programs, one in conjunction with the VA and UT Southwestern, where I was assistant professor of surgery. And then I opened Minimally Invasive Surgical Associates here in 2016 and currently serve as the Director of Metabolism and Nutrition at Methodist Dallas Medical Center. We do a lot more than just operate. We've published, we have many publications, book chapters, national presentations. I've always been actively involved in resident education, and so I train future surgeons. I currently actually train active surgeons who are looking to expand their practice. and am a key opinion leader for Intuitive Surgical. And so we do a lot of speaking for Intuitive to talk about different robotic surgery options. To date, we've done over 5,000 surgeries, and I'm double board certified in both general surgery and obesity medicine, as well as fellowship trained in bariatric surgery. Technically, there is no board certification for bariatrics, but there was extra training involved in doing that. So where do we operate? We spend the vast majority of our time at Methodist Dallas Medical Center, just outside downtown Dallas. For insurance reasons, sometimes we have to take patients to other hospitals as well. Those hospitals include Medical City, they include Dallas Presby, as well as City Hospital White Rock. City Hospital used to be known as Doctors Hospital and Baylor White Rock. So that's where we go and do our work. But what really makes us different? There's a lot of bariatric surgeons out there, whether you're talking about the Dallas-Fort Worth area or beyond. But what really makes us different? And that's, we're not a factory. We're not here to push people through. We genuinely want to make sure that we are offering patients what they need to achieve their goals. And so because we can offer a variety of different medications, non-surgical interventions, and then all the surgical options that are out there, we feel like we're well equipped to do that without having to be a factory. And so when only you have one hammer, you can only use that hammer, but we have many hammers, and so we can adjust the hammer for whatever kind of nail we're trying to hit. But we teach, we mentor residents and medical students. We publish, we write, we present, we care about how our patients are doing, and we like to be able to tell the world what we think we're doing well. So we care about these things. These things matter to us. So what are the health problems that come with obesity? There are quite a few, and obesity is a disease that we wear on the outside, and that's unfortunate, but oftentimes you can assume certain things about someone's health based on their size. And here's a short list. This is not a comprehensive list. Most notably, we talk about diabetes, we talk about high blood pressure, sleep apnea, problems with cholesterol, arthritis, but we do see other problems. We know that the heart and lungs take a beating in the obese. Pulmonary hypertension is real. We know that obesity sometimes stands in the way of fertility, as we have many female patients that struggle with hormonal changes associated with obesity and can't get pregnant. And then there are at least 9 cancers for which obesity has been implicated as a major risk factor. And so by offering people weight loss, whether it's through medications, through non-surgical or surgical means, by offering people weight loss, we know that we're helping them on a variety of categories. And so you may have seen this diagram before. In fact, if you come to our office, it's in one of the exam rooms on the wall in a large poster. But this tells you that what we can expect from bariatric surgery is real. We know that we are doing much more than affecting someone's weight. We are affecting their overall health dramatically. So if you speak about migraines, almost 60% of them will go away. Sleep apnea, up to 100% in some studies, will go away. 50 to 90% of high blood pressure goes away. 80% of diabetes goes away. Joint disease gets better 40 to 70% of the time. We know that overall quality of life goes up dramatically, and that if you look at at least 5-year mortality, you have about a 90% reduction at the possibility of dying in the next 5 years if you have bariatric surgery. And so this is really the true reason. This is not the bathing suit. This is not the mirror. This is what affects people's health, and this is why we do what we do. So obesity is literally the silent killer. You may be obese and you may understand that your quality of life suffers for a variety of reasons. However, what about the health problems that are coming with that obesity, and are those health problems actually hurting your health and your mortality? And so this was a really nice study published in New England Journal of Medicine, where very simply put, they looked at people when they were getting their driver's license renewed, and looked at them above a BMI of 45 or below a BMI of 45. And then they know that some of those people ended up having bariatric surgery, gastric bypass in this situation. And they kept calling them every year. They called them once a year just to see if they were still alive. And what they found was that people who had a BMI over 45 and never had surgery, or obese people with a BMI under 45 who never had surgery, stopped answering the phone. And that goes to speak to the improved mortality by having bariatric surgery. And so by doing these operations, we're actually eliminating the silent killer in the room. So medical weight loss is important. We do a lot of it. We have good friends and colleagues that are in the world of medical weight loss. It's important, but what we have to understand about medical weight loss is that not only is it very hard, but the durability can be called into question. And the reason for that is because you have to stay with the medications, or you have to stay with the plan forever. However, if you have surgery, you can't cheat on the surgery because the surgery goes with you wherever you go. And so whether you're talking about diet modification, whether you're talking about behavior modification, or combining the two, the durability comes into question after a period of time. And so you know that because you have tried diet and exercise programs and have struggled. And so that's why we offer surgery. So people are broken down by their weight by something called BMI, or body mass index. Body mass index doesn't take into account whether you are white or black or brown. It doesn't take into account whether you're a man or woman. It doesn't take into account whether you're 18 years old or 80 years old. BMI is simply a ratio of your height and your weight. And so you can see from looking at this graph, if you are 5'6" and 250 pounds, now your BMI is 40. And 40 is the general cutoff for what we consider morbid obesity. Now, if you are 5'6" and 215 pounds, then you carry a body mass index of 35 kilograms per meter squared. And that's where we start to see insurance coverage for people with some of the health problems that come with obesity. So generally speaking, above a BMI of 35 is where we will start doing surgery. BMI of 40, certainly without the health problems, but those people as well. So in terms of definition, we consider a BMI between 25 and 30 to be overweight. A BMI of 30 is considered to be obese, and a BMI over 40 is considered to be morbidly obese or third degree obesity. So this moves into the realm of non-surgical procedures. These are procedures, they require anesthesia, but they are not traditional surgery. And so there are basically two. The top one you see is endoscopic sleeve gastroplasty, and the bottom one is the gastric balloon, known as Orbera. And we're going to go ahead and show you those right now. It's important to remember that at this time, insurance doesn't typically cover either of these procedures. Orbera is not new. I think most people in the US feel like the balloon just came on the market. Balloons have been around for over 20 years, just not in the United States. Predominantly in Europe and South America, we have over 600,000 balloons that have been placed. And so they have a very proven safety profile. About 85% of patients are able to tolerate their balloon, but 15% feel like the balloon makes them uncomfortable for a variety of reasons, and then balloon needs to come out early. In general, balloons stay in for 6 months. And during that 6 months, we see gradual weight loss, especially in the first 3-4 months. And typically the weight loss then flattens out after about month 4, but it does continue in some people. There may be some upfront nausea or vomiting, typically for 3 or 4 days, and we control that with medication, and then it usually gets much better. But the balloon on average helps people to lose between 25 and 30 pounds. We do see more weight loss than that at times, but that's just an average. The second procedure is endoscopic sleeve gastroplasty, and this is a procedure that reduces the space or the volume inside the stomach. So I've got 3 videos here playing, and I'm sorry if this is a little bit confusing, but we'll start on the top left. So top left, you can see the view from an endoscope. This endoscope is down a patient's mouth. The patient is asleep. And we are literally grabbing tissue and pulling it towards the endoscope and then passing a stitch through that stomach. And so effectively what we're doing is we're making many, many pleats inside the stomach. And this sort of gathers the body of the stomach together, so there isn't much room. You can see on the bottom video there, we're tightening down those stitches, and then the little circle next to it on the right side is the actual new opening of the stomach. And so that opening becomes much, much smaller, almost like a surgical sleeve, but the stomach is not being actually removed. Because of the pleating effect, some people will refer to this as a accordion procedure. And so that makes good sense. But you see here the stomach is basically just getting a big volume reduction so that people eat much less and feel fuller, much easier to lose weight. The patients that undergo endoscopic sleeve gastroplasty need to remember this is not a surgical procedure in the traditional sense, but it is a major procedure. It's intended to be permanent. The stitches are not temporary. Stitches are not removable. It could be revised with a true surgical procedure if need be. The 5-year data shows that these people will lose on average 20% of their total body weight. Most of our patients are around 200 pounds, and so they'll lose about 40 pounds on average. That weight is typically lost within the first year, maintained through 2 years, and maintained through 5 years. So we're very happy to see the studies show that degree of durability. There is a risk of visceral injury to anything outside the stomach. That needle passes through and through. It could technically, it could kiss the colon or the spleen or the pancreas. Thankfully, the risk of that happening is incredibly low, less than 1%. And usually, even if that happens, patients don't have significant issues that require surgery, but it is a possibility. So what about surgical weight loss? So through and through, I am a surgeon, and so I truly believe in surgical weight loss. These are performed laparoscopically, so typically that means 5 small incisions on the patient's abdomen. These incisions are typically about 1 centimeter in size or smaller. One of them may be a little bit larger if I have to remove the stomach like I would during a sleeve, but in general, these are small incisions. That you can see a picture here. So we often do these operations robotically, and people sometimes wonder, well, what is the robot? On the right side, I'm controlling the robot with my hands. On the left side here of the picture, the robot is moving. I'm controlling the robot with my hands and my feet. And so I am controlling every step of the robot. There's no autonomy of the robot. It's not doing the operation for me. I am doing this operation. But the robot allows me to see things in 3 dimensions. It allows for better visualization, more precise surgery, and our outcomes actually show that our patients are doing better because of this. In general, there are 3 operations that are offered for obesity. The first is a sleeve, your second is a gastric bypass, and your third is a duodenal switch. And in general, as you go from sleeve to bypass or bypass to switch, you see more weight loss, you see more durable weight loss, and you see a little bit of a higher rate of vitamin problems should someone not be taking their vitamins. Of course, after these operations, the intestines have been adjusted, and so people are not going to absorb food or vitamins the way they normally would, and that's why it's important to supplement with extra vitamins. So sleeve gastrectomy, it's only been around for 10 years. There's often this perception that maybe it's been around for much, much longer. That's not true. So it's been around for about 10 years, typically involves 1 night in the hospital. The procedure takes about an hour, resulting in a banana-shaped stomach. And so the stomach is generally the size of a football. And when we finish the sleeve, it's the size of a banana. Results in about a 60% excess weight loss and a 60% diabetes resolution in general. Medications are absorbed normally. Food is generally normally absorbed. And this operation works by restricting the space within the stomach as well as dramatically reducing ghrelin. Ghrelin is responsible for our hunger. It's the only known hunger hormone. But when ghrelin is up, hunger is up. And so ghrelin goes way down with this surgery, which helps people to feel less hungry. This is the lowest risk of the operations, but the risks that we typically cite specific to sleeve are possibility of leaks. Leaks happen 1 in 400, 1 in 500, maybe even less than that in a low-risk patient. And heartburn. If that heartburn causes problems in the long term, we don't know, but about 15% of people have significant heartburn after their sleeve. 10-year data shows that the sleeve is safe because we've removed part of the stomach. It's not reversible. And if you're looking at what the vitamin requirement is, typically it's 1 vitamin in the morning and then a calcium later in the day, plus another calcium. Sleeve can be revised if need be to an alternative operation, but not necessarily to a sleeve. It can be revised to a gastric bypass. It can be revised to duodenal switch, but revision of a sleeve to another sleeve is rarely performed. Second operation to consider would be a gastric bypass. Gastric bypass has been around since 1961. It is considered to be the gold standard in bariatric surgery because it's been here so long. We know the risks, we know the benefits, we know the outcomes. Typically, the operation takes about an hour and a half, results in a 70% excess weight loss. So if someone's 100 pounds, they should be estimated to lose about 70 pounds. 70% diabetes resolution. Your new stomach that you can see here in the picture is about the size of an egg, but it doesn't have a valve. So typically people can eat about a fist or an apple-sized worth of food at a time. I put irreversible here in quotation marks. It can be reversed, but it's not exactly straightforward to reverse. You have to put the stomach back together and the small bowel back to its old small bowel, but it can be reversed if need be. But of course, you would have scar tissue after that as well. And there are very few reasons to ever need to reverse a gastric bypass. This also is considered to be a very low risk operation, but risks include leaks, hernias on the inside, ulcers between 5 and 10%, vitamin deficiencies less than 2% of patients, and then dumping syndrome. 15% of people have dumping syndrome. And what that means is if they consume more than 10 or 15 grams of fat or sugar at one time and mix it with liquids, they may have significant diarrhea, flushing, low blood pressure. And so dumping syndrome helps to keep people away from some of those things. But not all gastric bypass patients have dumping syndrome. But the good thing is if you do have dumping syndrome, it keeps you away from some of the bad calories that may cause weight gain. And then lastly, we'll speak about duodenal switch. Relatively few surgeons do duodenal switch. It's considered to be the most aggressive of the surgeries. It results in 80 to 90% excess weight loss, about a 95% diabetes resolution rate. So excellent for weight loss, excellent for diabetes resolution. But it's the least likely to have any weight regain issues. We see our patients lose weight for about the first 2 years, and we've seen people lose in excess of 300 pounds with this operation. Typically it takes up to 3 hours, and in addition to the regular vitamins, we have to be especially aware of the fat-soluble vitamins being a problem. So vitamin A, D, E, K, and of course we supplement you with those vitamins so that those aren't a problem. The risk of surgery is low, but those risks include leaks, injury to anything on the inside. And then because we're bypassing so much of the intestine with a duodenal switch, fats don't get absorbed very well, and those fats can give someone very bad, smelly gas, diarrhea, etc. We really try to stress to our patients that vitamin compliance, taking your vitamins, taking your calcium for the rest of your life is extremely important with duodenal switch. We need to make sure that all your vitamin levels are okay, especially so that your bones stay strong. And truthfully, it's not usually a problem when people are taking their vitamins. It's more a problem when they don't take their vitamins. So what does the process look like? Well, once you're establishing your care with us and we're trying to move things forward, we have to look at what the insurance requires and what our program may require. Different insurance plans require a different degree of duration for your medically supervised weight loss. They may require them over a certain period of time. They may require them to be over consecutive months. They may require a mental health evaluation because of the changes involved in bariatric surgery. And they may ask for primary care clearance or documentation of medical benefits. We'll help you certainly with all of those things. On our side, we often require that our patients go to a class because we want you to understand the changes that come with surgery. And we want to make sure that you're healthy enough for surgery. And so cardiovascular examination, upper GI examination may be part of the workup, as well as a stress test. Recovery is always a big question, and we're doing these through small incisions. We're doing lots of nerve blocks to help limit pain, lots of adjunctive pain medication measures. So typically recovery is not too bad. Most of our patients are in the hospital just one night. Some patients even leave the same day. This pain that you may have will last 4 or 5 days as the incisions heal up. After surgery, patients are on liquids for 2 weeks and then soft foods for 2 weeks. But overall, with respect to pain, about 15% of our patients need narcotics. Most patients don't need narcotics. And so you have to remember that when people get started on narcotics for surgical pain, 7% end up getting addicted to those narcotics. And so we definitely want to try to avoid starting those narcotics to stop that addiction before it ever starts. The other thing to consider is not only the addiction potential, but when we prescribe narcotics, about 60 to 70% of narcotics never get completely used. And so we're probably prescribing narcotics unnecessarily. So we have a narcotic minimization program, and we're very proud of that. Our patients are generally very happy with that. Of course, we're never going to deprive anybody of pain medications if they need them. But this is a patient that you see of ours. She happened to have her surgery the day before one of our in-person support groups. Incidentally, this patient came all the way from Arkansas to have surgery with us, but we had an in-person support group the night after her operation. She was still in town, so she thought she would just go ahead and come to the support group, and she was up and kicking, and she looked great. And then here you see her about 5 months later wearing exactly the same clothes, and how much different she was. But she recovered well, and pretty much as everybody does. So these are only tools. Surgery is great, surgery is effective, surgery is durable, surgery works, but these are only tools, and they don't work if you don't use them, just like anything other tool. But they do give you the time in the first 6 or 8 or 12 months after surgery to start making changes to your mindsets, to your behaviors, that if those changes stay with you, you will be successful in the long run. And so these tools are there to help you along your journey. We both have responsibilities. You have a responsibility, I have a responsibility, and our job is to help you through this process. We're not here to judge. We're here to take care of you. We're here to make sure that the process is as easy as possible and keep you in the loop. But on your side, we need your help working with the insurance companies. We have to work with them as well, but we need you to help verify your insurance to make sure that what you find with your insurance review is in agreement with what we find. Please stay on track. And if you can't stay on track, please communicate with us so that we can help avoid any problems before they start along the way. And so next steps from here, we ask that you figure out if you're going to be a self-pay patient or if you're going to be using your insurance. Either way, we can take care of you. Enlist the support of others. If you're using your insurance, please verify your benefits, and then enlist us to help. So if you go to our website, www.misadallas.com, very quickly you'll see the free insurance check. If you complete the free insurance check, you will promptly be getting automated text messages to let you know what your status of your insurance is, and you make your appointment. We're happy to verify your insurance for you for free to get this process started, so that you know where you can go next. Our office is located on the campus of Methodist Dallas Medical Center, just outside downtown Dallas. You can see here, we're just west of downtown, just east of Grand Prairie. So centrally located to help you. And we're actually not even that far from Arlington and Fort Worth. We have quite a few patients coming from that direction as well. So our number is 469-620-0222. Our website is there, MISA Dallas, MISA Dallas.com. Our Facebook page has a support group as well as daily content. We would love it if you joined us there at Sachin Kukreja, MD. So that's the end of our information session, and we hope to be able to take care of you as you get started on your journey. Thank you so much for your time and your attention. Bye-bye.